Hello everyone. My name is Mohammed Gresha. I'm one of the A&E registrars in Lincoln County Hospital. I will be with you for the next few minutes. We will talk about chest pain. Uh, from that session is to be familiar with the one of the most common presentation in ED. It's about 5% of presentations and 25% of admission in England and Wales, and also to be familiar with the red flags of chest pain and with our local protocols as well. What should we do? I know you might be familiar with these cases, but it's just like a refreshment and to know the local protocols for our hospital. So let's start. It would be about 5 cases. We will go through some discussions and we will show the local policies for each one. First case with us is this is a P2 patient. This is a 55-year-old man who self-presented with a chest pain for a few hours now. The nurse did an ECG and showed to a senior who didn't see any abnormality. The nurse was still concerned about him, and he didn't look right for her. So she was advised to prioritize him as a P2, and unfortunately, the ECG, the initial one, was lost, and you go to see the patient. His background is only hypertension. Uh, these are the patient examination finding. So the airway is patent, and the patient was looked quite pale and diaphoretic, and that was the main concern for the nurse. Chest looks clear, respiratory rate 25, sats 100% on air, heart rate 50, and blood pressure 100/96. He is alert, PM is fine, so you requested a new ECG. Here we go. So what do you see in that ECG? I'll just give you a few seconds. You can just pause the video and try to figure out what's wrong in that ECG. All right, so we can see clearly that there is an ST elevation in inferior leads, which is 2 and 3 and AVF. And there is also reciprocal changes in lead 1 and AVL. And the patient also has a sinus bradycardia. So this is a STEMI. So what should we do for that patient at the moment? Yeah, just pause the video again and try to think, what should we do? All right, so for a STEMI patient, we have in our hospital a 24/7 cath primary PCI. So we are lucky to have this facility at our hospital. Usually the patient will be diagnosed if they are arriving with the EMS, so they will be referred directly to the primary PCI. We usually don't see STEMIs frequently, but because that patient was self-presented, so we still seeing these patients. It's not frequent, but you need to pick them up early because time equals muscle in that patient. So whenever you pick up these patients early, so the proper management will be done. So you call this is a STEMI number. So you need to call them directly and refer the patient to them and start the management. Of course, you already you need to make sure that the patient had the full assessment, the ABC, had the treatment which we will give. We will give aspirin, we will give nitrate if the blood pressure allowing, and make sure his oxygenation and ventilation is maintained. Troponin is being sent. We will not depend on troponin in such patient, but just to have like a baseline troponin level, and refer to the STEMI number. And so the cardiac ACB should come immediately and see that patient and take them to PCI. The patient is already being referred to the So if we are talking about the cardiac chest pain, you can see here is the most common like presentation of the cardiac sounding chest pain with the Socrates analysis, but it's not necessary to be like that. The central pain radiating to the left, heaviness, pressure like radiating to the arms, jaw, throat, may be associated with nausea, vomiting, sweaty, shortness of breath, related to exertion, exercise. So yeah, this is the most common, but it's not necessary to be like that. For example, in diabetic patient could be asymptomatic. Yeah. So just have a high index of suspicion in especially for the high risk patient would be appropriate. And also for some patient with the inferior STEMI could present with like a heartburn or maldigestion symptom. So not get fooled by these presentations. So this is the like pathway for the cardiac sounding chest pain, if not STEMI. So if the patient presenting with cardiac sounding chest pain, this is the pathway for them. I'll try to make it the algorithm for the troponin. So after you did the ECG and no ST elevation or ST depression with that chest pain, we part of the bloods we are doing is the troponin, the high sensitive troponin T. So if the troponin is less than 5 and the pain, worst pain is more than 2 hours, and troponin now is negative, so we'll do the heart score and we'll follow the other flow chart. If the troponin between 6 and 51 and the patient still have that chest pain, so we need to repeat the troponin in 1 hour and look for any absolute change. So if the absolute change is more than 3, so we will do the heart score and we will see if the patient is moderate or severe according to the algorithm of the heart score and to see where will be the destination. If the absolute change is less than 3 and the presentation was late, so the worst pain was more than 12 hours, because you know that troponin usually take a few hours to 4 to 6 hours just to raise. So if that late presentation is more than 12 hours, so we can have now like a reliable reading for that troponin and is not that raised. So we can complete the heart score and we can consider the patient discharge or referral to SDCO Rapid Access Chest Pain Clinic. If the troponin is more than 52, so this is like a positive troponin and we need to complete the heart score and refer to the cardiac team. All right, so you will find all of these algorithms on the intranet, so you can refer to it back. This is the last one for the heart score, so this is what like a checklist for what you should do for any patient for within cardiac sounding chest pain. So make sure you requested the X-ray, the bloods, and the patient on a cardiac monitor if the score is more than 7. And observation is being done frequently, and you need to discuss with the EPIC or one of the seniors in the department. And this is the heart score. The criteria is basically the first letters of the history, ECG, age, and risk factors, and troponin. So after you completing the heart score, so here is the results. So if it's a low risk or intermediate risk or high risk, and this should be the destination that the patient should go for. Right, so let's move to the next patient. So this is a 40-year-old man presented to hospital with severe left-sided stabbing chest pain, worsening on inspiration. Ongoing since this morning. He rates it 9 out of 10, so it's a bad pain for him. He called an ambulance and brought to ED. There is no cough, no fever, but he is worried that could be COVID. Background is depression on citalopram. Here is the finding from the examination. Airway patent just clear, sweat rate 24, SATs is 97 on air, just clear. While you're auscultating his chest, he flinches when you press the left side of the chest wall. On further questioning, he mentioned he has been doing some do it yourself for the last 3 days at home due to some confinement. The pulse rate 98, blood pressure 118/65, heart is fine, ECG was normal sinus rhythm without any changes, and he's alert, no focal neurology. So, what you are going to do for that one? Yeah, sure. So we will do an chest X-ray, ECG, and the differential could be PE to be excluded, musculoskeletal pain. So the ECG was normal sinus rhythm, and chest X-ray was unremarkable. So how can we exclude the PE for such patient with that kind of pain? We need to apply the pulmonary embolism rule-out criteria. And basically, if the patient met all of these criteria, so we can clinically rule out the pulmonary embolism, and we don't need to do any further investigations. Sorry. So if the patient is less than 50-year-old and the pulse is less than 100, SATs is more than 94 air, no hemoptysis, no exogenous estrogen, no previous DVT or PE, no surgery trauma within the last 4 months, and no unilateral leg swelling, so we can clinically rule out the PE. So that patient most likely musculoskeletal pain and can some pain management. And after the waiting blood result and chest X-ray, which came back fine, the patient had some paracetamol and ibuprofen, and he felt much better and self-discharged. So let's go for the next one. It's a 75-year-old lady presented to ED with a history of right-sided chest pain, worse on aspiration. So it looks like a pleuritic chest pain. This has been going for the last few days, but she didn't think much of it. It prevented her from sleeping though. So she called an ambulance. After analgesia, she felt much better. So her background is hypertension, diabetes, right breast cancer, and she had mastectomy and she was on HRT. The patient thinks the pain might actually be due to her breast cancer and feels much better. So this is the assessment. Airway is fine. Chest examination is fine. She's tender when you press the right side of her chest. Heart rate 70, blood pressure slightly high. Heart sounds fine. Your disability and exposure is fine as well, apart from slight hyperglycemia. What could be the differential diagnosis for this one? Yeah. What do you think about that pleuritic chest pain with the cancer patient? Yeah, so clinically, I need to exclude the PE. Basically, this is her ECG. It looks fine. Normal sinus rhythm. No major changes. And that ECG. And the chest X-ray. It looks normal as well. So if we try to apply the pulmonary embolism rule-out criteria, this will not fit for her because she is more than 50-year-old, and also there is a history of uh, that cancer. So this doesn't fit for her. the pulmonary embolism rule-out criteria because she's more than 50-year-old. So we need to go for another clinical tool we need to use to see if we had a PE. Go for the PE2 level Wells score. So basically the Wells score, these are the component of it. So you calculate it and to see if it's more than 4 points, so PE is likely, and if it's less than if it's 4 point or less, so PE is unlikely. By following that chart, we can we can see which patient can be discharged home and could be followed by the SDIC. So we will follow that algorithm here, and at the end, you need to apply all these exclusion criteria first, because if the patient had any one of these, so this doesn't fit for him. And then you need to apply the pulmonary embolism severity index, which is here. So if the patient also has the severity index is 1 or more, so this also need to be admitted in the hospital. Otherwise, so the patient can have an outpatient management. Basically, here would be the SDIC. So finally, you need to exclude all those two tables need to be cleared from the patient, and if he met these criteria, so we can discharge him for an outpatient treatment. So the patient had a CTPA which confirmed right-sided BE and started the treatment with the anticoagulation. And make sure when you are referring patient to SDIC and or there will be a delay to get the CTPA and the patient that met the criteria for ambulatory care, make sure that you prescribe them the anticoagulation and at least for 5 days until they got the imaging or start the next treatment. So this is a fourth patient. We have a 68-year-old man, Hungarian, presented to ED with left-sided chest pain, sudden onset tearing pain, radiating to the back. It was difficult to get a proper history due to language barrier. His past medical history is hypertension only. So what you are going to do with that one? Yeah, sure. Language line would be helpful to get a proper history from that patient because you need to have a good analysis for that pain and go through the past history. And these are the examination finding. Yeah, all are fine apart from borderline blood pressure and heart rate is 68. Otherwise, it's unremarkable. So what you are gonna to request now? Yeah, fine. So we will do an ECG, chest X-ray. This is the ECG. Yeah, just normal sinus rhythm. And here is the chest X-ray. So what can you see in that chest X-ray? Yeah, I have heard some of the answers for that question in the patient. They said that there is a pneumothorax on the right side of the chest. But if you look to the trachea, you will be clearly that the trachea shifted to the right side, not the left. So the pathology on the left side. So you can find here like a white opacity here on the right side of the upper mediastinum, which we call a wide mediastinum, and that is part of what basic most probably is like great vessel problem. So with that patient with that kind of chest pain, you need to rule out aortic dissection. So we have here all patient will present to our department. You will find that sticker is being sticked on the front page and it's called True Man Show. So Truman Show was part of an audit being done earlier for the basically it's just trying not to miss any patient with aortic dissection. It's not a frequent presentation, we can see it every day, but it became one of the most common presentation that we need to roll out every day in our department for any patient presented with cardiac sounding chest pain or chest pain in general. So here are the Truman Show criteria. So you can just pick any of one of them. So these are the clinical risk factors. If there, so you need to suspect uh, more with the aortic dissection, and you need to pick at least two to proceed for the next step. And you will find that uh, algorithm. Also, you'll find it on the intranet. Basically, it's for just to memorize the risk factors, symptoms, signs, and treatment for the had a CT scan, and it showed that he had aortic. And the patient transferred to Boston under the vascular team, and later on to London for definitive management. Again, don't forget to use the language line if needed. The last one, this is you are starting your shift in ED, and the first patient you pick up is a 45-year-old gentleman who had a right-sided chest pain for 2 days of sudden onset with some tight chest. No past medical history apart from smoker, 5 cigarettes a day for 3 years. So, what you are going to do for that one? Yeah, here is the examination finding. Airway patent respiratory 20, SATs 97 on air, no bruise present on the chest, reduced air entry on the right side. Not sure about the percussion note, otherwise examination is unremarkable. So what you're going to do now, sure, ECG, chest X-ray, make sure the patient had a proper analgesic pointer at the moment. No, just here, yeah. All right, so we can see here the lung border just going down here. And all of that area is the pneumothorax, all of that part of the pneumothorax. So there's no air bronchogram here, no bronchovascular marking, but you can see it clearly here. I will try to zoom. It looks like a spontaneous pneumothorax. Actually, there is some also there is some surgical emphysema is there just under the skin here. So this is basically a spontaneous pneumothorax. So what should we do for that patient? An algorithm from the British Trauma Society, and this is what we are following in our department. So if the spontaneous pneumothorax, of course, if it's a traumatic pneumothorax, so this is another thing we can discuss later in chest trauma, but the patient in traumatic pneumothorax, he will need a chest drain and open technique and from 28 to 32 French diameter chest drain. But if it's spontaneous pneumothorax, so if it was bilateral or the patient hemodynamically unstable, which will be a tension pneumothorax, so you need to proceed for the chest drain. Okay. Otherwise, we need to see if that patient had a primary spontaneous pneumothorax or secondary spontaneous pneumothorax. So here for the primary pneumothorax, you need to see if the patient is more than 50-year-old and there is a significant smoking history, or there is an evidence of underlying lung disease on examination or chest X-ray. In that situation, that would be a secondary pneumothorax. If not, so this is a primary pneumothorax. So for that patient, he is 45-year-old, so less than 50, and actually, it's not a significant smoking history. 5 cigarettes a day for 3 years is not a significant smoking history. And the X-ray didn't show any underlying problem apart from the pneumothorax. So that is a primary pneumothorax. What should we do? We need to measure out how much the size of the pneumothorax. Usually the size of pneumothorax we will start to measure from the lateral chest wall to the lung border at the hilum level. So on that level, that arrow here. So if that measurement is more than 2 centimeters or the patient is breathless, so we will do an aspiration. So needle aspiration with 16 to 18 gauge cannula and aspirate for up to 2.5 liters of air. If not here, so we can consider discharge patient and review in outpatient clinic, and usually here it will be the SDEC in 2 to 4 weeks. So you need to do a referral for the SDEC. And if the patient went for an aspiration, so we will do an X-ray after that. If it was successful, and that means that it became less than 2 centimeters and the breathing problem improved, so also discharge the patient with SDEC review in 2 to 4 weeks. What if it didn't improve after the aspiration? So we will go here for a chest drain, 8 to 14 French, and then the patient to be admitted. All right, so this is the algorithm for the primary pneumothorax. And for the secondary pneumothorax here, the patient, we will also measure the distance. So if it's more than 2 centimeters or the patient is breathless, so we will go directly for the chest drain here. If not, so if the size between 1 to 2 centimeters, yes, so we will go for aspiration first. If it's successful, we will admit for high flow oxygen. If not, so we will proceed for chest drain. If the size is less than 1 centimeters, so we could consider admission of the patient and on high flow oxygen, unless there is a problem on the like a COPD patient, and observe for 24 hours and then to be reassessed. So what can we exclude from here? That the secondary pneumothorax, he should be admitted in the hospital. You can't discharge a patient with a secondary pneumothorax. Whatever you will admit for observation, or you he already have a drain. So you can find this algorithm also. You can find it just because I tried to find it on the internet. I didn't find it, but this is the one we follow. So again, never discharge a patient from the ED with diagnosis of secondary pneumothorax. At least admit for supplemental oxygen and 24-hour observation. Supplemental oxygen for a pneumothorax will resolve will help the pneumothorax to be resolved up to 4 times faster if so if we give oxygen, so it would be faster in the resolution 4 times if not without an oxygen. So give the patient high flow oxygen if not contraindicated. So the learning points from that session, don't forget to request a chest X-ray for patient presenting with pneumothorax. Don't underestimate the patient that walk in. It might present with STEMI. If you discuss a patient with the chest pain, we will ask you to see the ECG. So please make sure that you had all the details while you're discussing the any patient in general. Cardiac ACP insights, but don't overuse them, please. So discuss with your senior first and escalate if needed, because this is what we are here for. We need to see our patient to assess them and only get help from the specialty, whatever the specialty, just in case, just if needed. Otherwise, we need to do our jobs. I hope you enjoyed that session. Thank you so much, and I hope you enjoy your stay in our department. See you later.